So, good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar on menopause management organized by Mumbai Menopause Society. And I would like to uh, thank all the organizers for this arranging such a wonderful webinar today. And I asked participants to uh, paste their queries in the comment box so that we can have a session with the speakers following the presentation. And now I would like to introduce the masters of today's ceremony, that Dr. Kinjal Shah and Dr. Riti Desai. Kinjal Shah is a consultant obstetrician and gynecologist at Bhatia Hospital, Wakata Hospital, Lakshmani Hospital, St. Elizabeth Hospital, and Apollo Hospitals. And she is also a member of Youth Council member of MOGS, and she has special interest in laparoscopy, high risk obstetrics, PCOS, and adolescent health. Coming to Dr. Riddhi Desai, ma'am, she is a consultant endoscopic surgeon, gynecologist, and obstetrician practicing Vile Parley, Juhu. And she's a member of Foxy Endocrinology Committee and Youth Council MOGS and UR late 2021 MOGS. And she's a certified medical writer and peer reviewer of journals of obstetrics and gynecologist India. With this introduction, I would hand over the session to Dr. Riddhi Desai, ma'am, for their further progress. Thank you.
Thank you, Dr. Stalin, for the kind introduction. I extend a very good evening and a warm welcome to all of you on behalf of the Mumbai Menopause Society and the conveners of this program. Today the society, Mumbai Menopause Society is dedicated to easing the pause. And today we will be listening to some very unique and practical topics to do the same. Our first session, I would like to call our chairpersons, Dr. Sujata Dalvi, Dr. Preeti Vyas, and Dr. Nidhi Gandhi. Dr. Stalin, could I have their CVs, please? Dr. Sujata Dalvi, she is a consultant obstetrician and gynecologist at Global Saifi Bhatia and other prominent hospitals around Mumbai. She is the honorary clinical associate at Naurozji Wadia Maternity and Jagjeevan Ram Railway Hospital. She is the treasurer of Mumbai Menopause Society. She is the assistant editor of Jogi and the member of managing council of MOGS. She is the first joint secretary of AMOGS. Our next chairperson is Dr. Preeti Vyas. She is a consultant obstetrician and gynecologist and laparoscopic surgeon at Sangeeta Maternity Surgical and Diagnostic Center, Hinduja Khar, KLS Memorial, and Surya Mother Care Hospital. She is MSc in psychology and psychological counseling and therapy, and she is the managing committee member of MOGS, and she is the youth council mentor. She is a national coordinator and trainer of Youth Mela Foxy. Our next chairperson is Dr. Nidhi Shah Gandhi. She is a consultant at Women's Care Clinic, Hughes Road, Connect and Heal Clinics, and Jaslok Hospital and Dr. Vora's Maternity Clinic. She is a visiting colpologist at Cytological Clinic at the Kama and Elbrus Hospital. She is the active member of Foxy, MOGS, and AMWI, and she is the recipient of Golden Jubilee Award for thesis on endoscopy in 21st century. I would like to now hand over to our chairpersons. Dr. Sujata Dalvi, ma'am, will be joining us shortly. Thank you.
Thank you. Thank you, Riddhi. Thank you, Riddhi, for a nice introduction. So let's start the program. I think we have a good audience today. We're really looking forward to expert by all expert speakers and panelists. So can I have Dr. Geeta Balsarkar's CV, please? Can that be put up, please? Can somebody share that? So Dr. Geeta Balsarkar is going to talk to us today about non-hormonal options or alternatives for treatment of menopausal symptoms. Dr. Geeta Balsarkar is, of course, all of us know. Can you please put it on the is the Vice President of the Menopause Society Mumbai branch. She's a professor at CGS Medical College and Naurozji Wadia Hospital. She's a clinical secretary at Mumbai Obs and Gynaec Society, the president of AMWI Mumbai branch, and is also the associate auditor of Jogi, the Journal of Obs and Gynaec of India, Foxy. Over to you, Dr. Geeta ma'am, for throwing some light on how to manage menopause with non-hormonal options.
Can I share my screen?
Yes, ma'am, you can share.
Yeah, I'm sharing. Okay. Can you see now? Hello?
Yes, ma'am. Yes.
Yes, yes. Yeah, okay. The topic that is given to me is actually non-hormonal management of menopause. Whenever anybody, for that matter, even doctors or even patients, when we say that we have to do certain management for menopause, everybody thinks we are going to use hormones. So even doctors think, even doctors ask, oh, are you going to give hormones? And even patients feel that, oh, are we going to get hormones? But we have to understand that there is another aspect to treat menopause, which is the non-hormonal management of menopause. Now, I'm not going into great detail because of shortage of time about the symptoms of menopause and the various other things, but we will talk about it slightly later. But when we talk about management, whenever we are going to talk about management of osteoporosis, all of us know that calcium about 1200 to 1500 milligram per day in divided doses, vitamin D 400 IU per day or 600 IU per day in patients over age 70, or nowadays we give 60K once a week for 8 or 12 weeks, and then once a month for these patients. We also have to supplement these patients with enough phosphorus, magnesium. Don't forget the weight bearing exercises. And then when the newer options are there, we are not going to talk about HRT. My topic is non-hormonal replacement, and I'm going to talk to you about SERMs, that is the isoflavones in particular, used in the non-hormonal management of menopause. Now, when we talk about this, we have already talked about calcium, the vitamin D, the phosphorus, the magnesium, and we have to talk about isoflavones. Isoflavones, that is the drugs which are easily available today, and they are the phytoestrogens. And these phytoestrogens are the next frontiers in nutrition of menopause. What are phytoestrogens? They are plant chemicals that elicit estrogen-like response by virtue of their chemical structure. They are capable of binding to estrogen receptors, but the most important is they are estrogenic, that is, they have agonistic action in some receptors, and anti-estrogenic, that is antagonistic action in some receptors. So wherever we need agonistic action, we can exploit those, and wherever we need antagonistic action, we can exploit those. So these are phytoestrogens, and they have varied, because of their chemical structure, they have varied functions, like they can act like an estrogen or they can act like a anti-estrogens. Hence phytoestrogens may be described as naturally occurring SERMs, or natural selective estrogen receptor modulators, since they have both agonistic as well as antagonistic action. Why phytoestrogens are becoming very popular? Because they have multiple target systems with all the benefits of estrogen replacement, but no risks and no side effects. So phytoestrogens can act on bone, they can act on uterus, they can act on breast, they can act on lipids, they can act on brain, they can act on all the organs that need estrogen. So what are the sources of phytoestrogen? More than 300 foods have been shown to contain phytoestrogens, but most food phytoestrogens are in isoflavonoids, which are found in beans of the legume family with soya beans as a major dietary source, and then the ligands, which are found in high fiber foods like cereals, grains, flax seeds, and the comestans, that is various beans such as split peas, long beans, alfalfa, and the clover sprouts. So these are main three sources of phytoestrogens: isoflavonoids, ligands, and the comestans. If we divide it into isoflavonoids, ligands, and others, the isoflavonoids are further divided into isoflavones and the comestans. And of the isoflavones, there are three further subtypes like genistein, daidzein, and glycetin. So these are the further three types of isoflavones. So what are isoflavones? By virtue of their chemical structure, isoflavones are very effective phytoestrogens. Isoflavone bioavailability is complex and is influenced widely by source with subsequent variations in the metabolic impact. Amongst all available phytoestrogens, soya isoflavones are found to be the most effective. So they in Japan, they consume and they found that those people had very less menopausal symptoms. So isoflavones are also found in other foods: chickpeas, very commonly consumed in India; clover, Alfalfa sprouts, they are the other types which give isoflavone in foods. The sales of supplements that contain soya isoflavone, a form of phytoestrogen, almost tripled in 10 years from 1998 to 1999. This is stated by the Time magazine in 2000. It said that the isoflavones are found a very real plays in management of menopause. Now, genistein is the isoflavone that has been extensively studied, is the most studied of isoflavones. At some places, it really mimics estrogen by stimulating estrogen receptors, even though the potency is very weak. At other places, by binding to these receptors, genistein block the availability of far more estradiol to activate the receptor. Hence, it acts like a anti-estrogen. So they act on the beta receptors of the bone, the liver, the brain, and the alpha receptors as the breast or the uterus. Wherever they stimulate the beta receptors, they are like an estrogen agonist, and wherever they act on the alpha receptors, they are like estrogen antagonist. So the metabolism is the ingested isoflavones are absorbed, and then very important to remember, they are biotransformed by the intestinal microflora. Hence, it is very, very important to have intestinal microflora which can transform your isoflavones. Then they undergo enterohepatic recycling by to reach the circulating concentrations that exceed by several orders of magnitudes the amount of endogenous estrogen, because a large amount of isoflavones are required to create action that normally a small amount of estrogen does. These phytoestrogens and their metabolites exert many potent hormonal and non-hormonal activities that explains the biological effect of the phytoestrogens. They what all are the isoflavones used for? They can be used for hot flashes. The severity of hot flashes is assessed in a 6-week study by the green climacteric scale. They saw a reduction in the mean number of hot flashes per week was observed. So, but no soya related changes were observed in the vaginal cytology, the endometrial thickness, where we don't want the estrogen action, the uterine artery pulsatility index, and the metabolic hormonal parameters. So isoflavones were found to be very useful in the hot flashes. Now, what about the cardiac disease? Isoflavones prevented the cardiac disease by preventing oxidation of lipoprotein particles, by preventing cell adhesion, altering the growth factor activity, and inhibiting progression of the atherosclerosis. So it prevents the cardiac dysfunctions also. Then what about this in cancer? Isoflavone activities on the breast and uterus induces apoptosis, inhibits differentiation in cancer cells, and inhibits cell proliferation. So it is very useful in cancer prevention also in the menopausal age group. It's also very useful in obesity and diabetes. Somebody is going to talk later on about obesity, but evidence is emerging that phytoestrogens play a beneficial role in obesity and diabetes. Nutritional intervention studies suggest that isoflavones alter the insulin resistance and the glycemic control, and alter the serum lipoproteins in the postmenopausal women with type 2 diabetes. Therefore, they improve the cardiovascular risk profile. So what is a dose? Soya sauce and soya bean oil contain almost no isoflavones. 40 to 60 milligram per day of isoflavones are needed for effects on the arterial compliance and for the antioxidant effect on lipids. As little as 10 milligrams per day may be effective. Most studies on hot flashes have used isoflavone amounting to 40 to 80 milligrams per day, and these amounts will benefit the vasomotor symptoms. So we need at least 40 milligrams, can be increased up to 80 milligrams per day. Now, another drug which I would like to talk about is the Dalbergia Sisu. A lot of studies has been done by the Mumbai Menopause Society, Dr. Rama Vaidya and Dr. Meeta Singh from Hyderabad on this Dalbergia Sisu, and they have found it very, very useful in the bone health. It is North Indian rosewood, and it is a fast growing and deciduous rosewood tree native to the Indian subcontinent. It's a large crooked tree with long leathery leaves, and lot of studies have been done which shows that it is very, very important for the bone health. It is also it was prominently used for teeth brushing by our previous generation. They used to use it for teeth brushing, and it is very, very important for bone health. It's an Ayurvedic botanical, and it has demonstrated bone anabolic activity. Dalbergia sisu extract in animal models increase the bone formation, reduce the bone resorption, and accelerated the fracture healing. Non-hormone therapies including low-dose selective serotonin receptor inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, and gabapentinoids can also be used to reduce the hot flashes. Non-pharmacologic intervention have weaker evidence, but it could include weight loss, hypnosis, cognitive behavioral therapy, yoga and acupuncture. These are also can be used for the treatment of menopause. So the main important thing in the treatment of menopause is prevention. It is menopause is a natural and expected part of the woman's development and does not actually need to be prevented, but the complications need to be prevented. You can reduce the risk of long-term problems like osteoporosis and heart disease by controlling the blood pressure, cholesterol, and other risk factors for heart disease. Please reduce smoking. Cigarette smoking itself can cause early menopause. A low-fat diet is recommended. Regular exercise. Exercise helps strengthen the bones and improves your balance. Very, very important, the balance. The D3 levels are also very important to maintain the balance. If there are signs of bone loss or there is a strong family history of osteoporosis, we must consider giving some form of treatment, and calcium and vitamin D have to be taken. Health education on menopause is very, very important, and counseling is required for each and every patient. Women at menopausal stage, they need to be supported emotionally. They will need counseling. They need to be educated about the signs and symptoms of menopause. This may also help them overcome symptoms of anxiety and depression. Lifestyle modification, very, very important for all age groups today. It is necessary to prevent the occurrence and minimize the associated conditions. To reduce hot flashes, just adequate, not too warm. We have to lower the heat, cotton clothes, use a fan, prevent tea, coffee, cola beverages, no smoking, learn to relax, exercise, and to take plenty of fluids. Then other non-hormonal treatments are behavioral methods like lowering room temperature, dressing in layers of clothing that are very light, and avoiding triggers. Very important to avoid triggers like spicy food, stressful situations. Some clinicians recommend vitamin E to women with high more hot flashes because at low doses it is well tolerated and not associated with toxicity. Another thing is vaginal dryness. A lot of menopausal patients complain of vaginal dryness, so we may have to use lubricants like Vaseline or oil that can be used. Urinary incontinence, exercises to strengthen the pelvic muscle incontinence. When the bladder is empty, we have to teach them Kegel's exercises to be performed several times a day to prevent urinary incontinence. And to prevent gynecologic cancer, they have to perform their own breast examination, annual clinical examination, mammography every 2 years, and the pap smear or the exfoliative site cervicovaginal cytology. To prevent cardiovascular diseases, fat diet rich in olive oil, which helps regulate cholesterol, healthy diet rich in fruits and vegetables. 5 portions of fruits and vegetables are said to be very important. Control of blood pressure, rule out hypertension, exercise, and counseling. The monitor BP, glucose, lipid profile, thyroid function, regular pap smear, mammogram, colorectal cancer screening in those who have family history of colorectal cancer, bone density testing if you feel that they are already osteoporotic, safe sex, fall proofing recommendation for seniors, adequate D3 levels. These are all very, very important in the non-hormonal management of menopause. Like there are inconsistent evidence of the black cohosh, acupuncture, paced respiration, mind-body therapies, and ineffective treatment is evening primrose oil and others like ginseng, wild hemp, traditional medicine, Chinese herbs, magnetic devices. A lot of studies have been done. They have found no beneficial effect. Thank you. Thank you very much for a patient hearing. I hope I have kept to my time.
Thank you, Dr. Geeta. I think that was a very concise and a lot of knowledge packed in a very small capsule. And yes, you were very much in time. Do we have time for one or two questions, or do we have to go ahead with the next session? Priya? Priya, you're muted.
Priya, you can go.
Yeah. You can take a question now or
time
keep.
limit. Priya, we can go for some questions just now.
Yeah.
So, Dr. Geeta, I'll ask you something. Also, there is a lot of talk right now on some newer herbal preparations available. One is that black cohosh, and the second is some molecule called ERR731. Would you have any inputs to give on that?
No, I didn't find any references as to ERR73 that has been, certified for use for menopause. There are, of course, some papers are there which they have been used, but not in a very large numbers. And black cohosh, they have said, is ineffective.
Okay. I don't think there are more questions on the chat right now.
You can
think
take them
I'll ask.
again if after the next talk there are questions.
Yes.
Yes, ma'am. Yes. I think Dr. Nidhi, you can take over now.
Thank you. Thank you, Dr. Geeta, for a wonderful talk. We now move on to our next talk for the session. Can I have the introductory slide, please? Dr. Yojana Mange is going to be talking on aquatic therapy for pre, peri, and post-menopause. She is a senior women's healthcare physiotherapist, Aquacentric Private Limited, certified and practicing aquatic therapist, certified childbirth educator, Pilates trainer, instructor with WOW International Institute of Pelvic Floor Research, Rehab and Education, certified non-invasive pelvic floor rehab practitioner, lactation rehab practitioner, oncovaginal rehab practitioner, female sexual dysfunction rehab practitioner, menstrual health and hygiene rehab practitioner, and a former lecturer with MGM College of Physiotherapy. Wow, that's a lot of degrees and stuff. So we're looking forward to hear from you. Over to you, Dr. Yojana.
Thank you so much, Dr. Nidhi, for your kind introduction. So I'll just go ahead and share my screen. Okay. So today we're going to talk about aquatic therapy in pre, peri, and post menopause. So I know definition of a menopause or talking about menopause is something uh, every time we listen to it, but I hope I will be able to put a different point of view and a different light on the way we look at menopause. So as everyone knows, it's a complete or near complete stoppage of the ovarian follicular depletion, which leads to permanent cessation of menstrual cycle. It is a transition in which the woman has to go through a lot of physical, psychological, and social effects. And the ability to cope with all these things are impacted by the socioeconomic status, the income, the level of education, the work life, professional life, the social relationship. So we should look at menopause. It is a complex stage of life that represents both loss and a time to reuprising in one's life. So these are the different stages of menopause. We have the premenopausal stage where normal reproductive life is happening. Then slowly, as the estrogen goes on dropping, we come to the perimenopausal phase. Then the menopause where there is complete no menstrual cycle for a year, and then comes the postmenopausal phase. So if you can see, there are a lot of symptoms that come up during the perimenopausal phase and the menopausal phase, which are exaggerated in the and they increase during the postmenopausal phase. So today we'll be talking about the different kind of therapy approaches at the different phases and how we can address them. So the long-term effects of menopause that is mostly seen in the postmenopausal phase, as ma'am said, is the bone loss. So due to the bone loss, a lot of women experience fractures. They have loss of balance. They have history of falls. The other thing is the cardiovascular diseases. So postmenopausal, they have a high risk factor for cardiovascular diseases. There is a change in the lipid profile that is seen, that is increased in the LDL, and the body composition of the women changes. She starts gaining fat mass, mostly at the central abdominal area, and starts losing the lean mass. It's the effect of the estrogen. So as we know the effect of estrogen, all the hormonal effects of estrogen, estrogen also maintains the thickness of the skeletal muscle. So the strength and the thickness reduces as the estrogen starts depleting and starts showing onto the loss of the lean mass post-menopause. All these again leads to the balance issues. So the women start having a lot of balance issues, which leads to decrease in their activities. The energy expenditure decreases, and eventually the metabolic rate also starts depleting. So all these things together become a very big barrier in participation. All these things contribute a lot when she has a lot of uh, symptomatic trauma. The physical activity reduces, the social stigma, and the lack of social support is a very important thing that pulls her back from participation in the normal life and starts affecting her quality of life. Now, this menopause is a significant opportunity to reintroduce and support physical activity behavior. Now, almost one third of the women are known to drop off their activity level post menopause, but they have a desire to stay active. So it's very important as a healthcare professional that we empower women and make them look at this as a new beginning and give them guidance for safe physical activity. As everyone knows the effects of physical activity, there are a lot of benefits of physical activities on the different aspects and symptoms of menopause. It will help maintain a healthy weight. It will improve the quality of life, work on the psychological aspect by the release of endorphins and caffeine, the hormones. Very importantly, to improve the genitourinary problems like ma'am said, stress urinary incontinence or female sexual dysfunction that is caused by the loss of or the depletion of estrogen can be taken very good care with physical exercises. Like ma'am has mentioned Kegels. So like every woman is different, every perineum is different, and every woman needs a custom made, tailor made pelvic floor rehab program. So Kegels is not one size fits all, but a, a pelvic floor rehab practitioner or expert needs to step in to take the call and see how to progress with the pelvic floor rehab. Along with that, the overall musculoskeletal and cardiovascular benefits are also seen with exercises. As I said, now the recent development in pelvic floor rehab, we have a lot of technologies to treat the pelvic floor and take care of the vaginal dryness or the hypotonic pelvic floor, which can lead to a lot of dysfunction, mechanical dysfunction like incontinence, but can also cause a problem in the female sexual normal function. So we have a different types of instruments to take care of it. One more important thing, when we look at the overall body, the core muscles play a very important role in rehab. We should not neglect the core muscles along with the other musculoskeletal system, cardiovascular system. Now, the current medical literature, which looks at the benefits of physical fitness in the midlife and postmenopausal women, have shown that there is a reduction and avoidance of obesity if done at the premenopausal stage. The long-term physical exercises can also reduce osteoporosis, osteopenia, and also reduce the risk of falls and fractures. The physical exercises that are beneficial are aerobic exercises, the resistance exercises, stretching, balance exercises. Also, mind and body exercises like Pilates, like yoga can also help to uh, cope with all this issues. The conclusion we come to, the conclusion of the study was it is exercise is an beneficial, inexpensive, and a minimal risk uh, uh, intervention to maintain a healthy goal and make it a point that the women participate in her regular life with a good quality of life. Okay. Once you have all the tools ready, evaluation is very important. So as I want to mention, a proper history, proper documentation, and proper examination will give you an idea where to start with. That brings us to one new intervention or a new point of view towards menopause, that is aquatic therapy. So what is aquatic therapy? Aquatic therapy refers to the use of water. It can be in multiple depths. It can be immersion in a pool or a tank. And we have to apply the therapeutic interventions like stretching, strengthening, mobilization in this multiple depths is aquatic therapy. So how is it different from hydrotherapy? So basically hydrotherapy refers to application of water for internal or external purpose to treat physiological or psychological dysfunction. So what happens in the pool or multiple depths of pool using the physical exercise interventions is the aquatic therapy. So in aquatic therapy, we use different properties of water. As you can see in this picture, you see the moment the immersion happens in the water, up to what depth the immersion is there, that will show how much your body is offloaded. For example, if you are immersed up to the neck level, you are 90% offloaded of your body weight. That means you are just 10% of your body weight in the water. If you weigh 100 kgs on land, in the water you will be just 10 kgs. So as a physical therapist, I get more opportunity to work with the clients, and I get a upper hand to get the results which are mostly goal oriented. The properties like buoyancy of the water, the hydrostatic pressure, the temperature plays a very important role when we look at the therapeutic uses of the water. Okay, so exercising in water allows for reduction of stress on muscle joints, and aquatic therapy could be a very good alternative for women who experience pain during stress on the joints. So the benefits are the buoyancy protects the joints from a lot of stress. So it gives a upward thrust, a feeling of weightlessness, which can avoid the jarring of the joints. It improves the blood circulation. So the hydrostatic pressure of the water will give a natural stocking effect and improves the lymphatic drainage and the venous circulation. Therefore, it can help in the cardiovascular and respiratory system improvement. It improves the endurance, a comfortable environment for strengthening exercises, pelvic floor rehab along with core engagement. So functional training happens much more better in an aquatic environment as compared to the land. It can also be used to improve a lot of balance. So water gives turbulence, gives a lot of external force, which will revoke all the strategies of maintaining balance. Hence, we can improve the strength and balance at the same time. We have fixed protocols for exercise intervention. So a moderate amount of intensity for 5 days a week for 30 minutes would give you the desired result. So if you are want to achieve fitness, it should be 30 minutes per day for 5 days. If you want to gain weight gain, 60 minutes of moderate intensity per day for 5 days, or 60 to 90 minutes for maintenance purpose. So a moderate intensity of workout in an aquatic environment will give you the result. Now, these are the different tools and equipments that we use in aquatic therapy. As you can see, it is a variety of equipment. Some are buoyant, which is very difficult to push in the water. Some have blades, so it gives a resistance inside the water throughout the movement. So the moment you immerse into the water, the physics completely changes. Like on land, the center of gravity plays a role. In the water, center of buoyancy plays a role. So this matching of center of gravity and buoyancy helps a lot to bring about a therapeutic effect of the exercise. As you can see here, there are just a few videos of the different resistive exercises. So here, if you see, there is the dumbbells with the blades. So the fluid mechanics of these dumbbells are different as compared to these buoyant dumbbells. And both the exercises, a lot of core activity, a lot of pelvic floor engagement is brought about along with the effect of weightlessness. So the buoyancy is helping you to avoid undue stress on the joints and also helps you to build up a lot of resistance in the upper limb, in the lower limb. And the hydrostatic pressure again gives a weight bearing effect. So start working on the bone deposition also. We also have an underwater treadmill and we can do underwater cycling. Now this is just a video of an underwater treadmill. So here you can see we have a camera planted inside and there's an underwater treadmill. So when the client is walking on the underwater treadmill, you are able to visualize how the client's biomechanics is happening, how the client is running, how is the leg movement happening. So a lot of arthritic patients who have alignment issues can be monitored under the water. So you see the client is doing back walking. So depending on what muscle activity you want, we tell the client to do according to that activity. Now this pool is in such a way that the floor length can be adjusted. If you remove the handrails, different, it can be used for athletic purpose also, advanced purpose also. So this is an advanced pool and the temperature of the pool is somewhere around 30 to 33 degrees. So they are all warm pools. Now, that brings me to another specialized aquatic technique, which is known as I Chi. So as there are a lot of research studies which show the effect of Tai Chi on land on osteoporosis. So Tai Chi is slow, controlled, active relaxation in the water. So it is a slow, controlled movement that is done with the breathing pattern. And again, the resistance of the water, the energy flow method, and this is an active induced technique. That brings me to another specialized technique named as Watsu. So Watsu is a passive relaxation technique. It's a form of water shiatsu. Shiatsu is a slow, controlled relaxation body movement that happens on land. This is in water where the client is completely taken in the zone of relaxation. Here you can see there are different techniques that are happening. Depending on what is the musculoskeletal issue underlying, we can move around the client passively to open up the muscle, to stretch the muscles. And the feeling of weightlessness again starts giving a lot of psychological well-being effect and will help a menopausal woman to cope up with the stress issues and also cope up with the other stiffness and muscle recruitment pattern issues. So this is what that brings us to there was a study done by Shiva Slicker in Finland where they saw 87 postmenopausal women. They had randomly assigned them to a group. The training group had 1 hour high intensity aquatic resistance workout, and the control group had everyday daycare and leisure activities. The results showed that the aquatic therapy group had slowed down or even ended the progression of the disease, that was the knee pain or the arthritic pain, and the body mass also decreased, the walking speed had increased, and the it was preventing the worsening of the condition. Now to support this, I will be sharing an internal case study. We had a 62-year-old postmenopausal woman who came to us with bilateral knee pain, left more than right. She had a lot of symptomatic complaints along with osteoporosis, a lot of SUI issues and all. So this was the pre-X-ray and post-X-ray. So for a year, she came to us regularly for workouts. She used to come 3 times in a week, and she consistently used to come and the reviews and all. So after a year, when we saw the X-rays, we could visually see the difference in the muscle orientation. So the patella, which was very laterally placed, had started to come to the midline. In the next slide, you can see the joint space had started showing difference because of the strengthening of the quadriceps muscle. So the alignment was improving. Symptomatically, she was definitely doing much better as compared to whatever she had tried earlier. So aquatic therapy definitely, and she was very obese. So she couldn't adhere to any land exercise program. So the aqua worked excellently for her with her increasing weight and increasing issues. Okay, so that brings us to the end of the presentation. If any doubts, these are the references. If any doubts, you can please put it in the chat box. I'll be happy to address to them. And one very common question is, where is all this available in Mumbai? So let me answer that question. So that gives me a privilege to introduce aquacentric therapy. It's the first India's holistic physiotherapy aquatic rehab center where we have land, air, and water as a rehab technique. We have neuro, pediatrics, women's healthcare, and orthopedics as a specialty verticals. And every vertical is being led by an expert physiotherapist. The founder of Aquacentric is Mr. Harsh Mariwala. The co-founder is Dr. Amit Kohli, who's a sports physiotherapist. And the leads have been to Switzerland and South Africa for the aquatic training. And we follow gold standard guidelines when it comes to treatment. We have 3 therapeutic indoor pools with underwater treadmills, pool bikes, and we have a hoist for heavy clients who cannot get down the stairs. The whole facility is wheelchair friendly. The filtration of the pool is maintained at the utmost at the international level. We have UV, we have ozone, we have glass bead filters, And the pool temperatures, as I said, they are warm pools. So the temperature is from 30 to 33 degrees. We have two centers, one is in Andheri and one is in Worli. We also have a land zone, medical gymnasium, and we also have an outdoor functional activity zone where we do a lot of functional athletic training. And that's it about. So if you want to get in touch, you can email me, get in touch with the center. So we have one center in Andheri West near Veera Desai Road, and one center in Worli, that is Bengal Chemical Century Bazaar. So please, I take this opportunity to invite you all to the center. Please come over, take a look at the facility, and we would be more than happy to give you an experience in the pool. Thank you so much for your patient listening.
Thank you, Dr. Yojana, for enlightening us with the advantages and benefits of aqua therapy in women, and for so many different medical branches, whether it's pediatric or neurology, etc. In fact, let me tell you that my granddad has been a patient at the Worli Aqua Center. He went there for a year for his spine, and it did improve a lot. So thank you. Any questions?
Can I ask one question?
Yes, ma'am.
Yeah. Yojana, now with this COVID time, is it still open, your aqua center? And if it opens, then what are the precautions which are being taken because of the COVID?
Yes, ma'am. So, ma'am, we are fully functional since September, and we make it mandatory that the client does the COVID test prior coming to the center. As we are maintaining the sanitization of the center, we have 3 indoor pools. So these are the pools here we have. And the pools, we take only 2 clients at a time with 2 therapists. So the appointments are managed that way. And we have full PPE kit, sanitization of the equipment, and social distancing maintained in the center throughout. So we've been functioning since 3 months now, and it's absolutely safe now.
But Yojana, can I ask something?
Yes, ma'am.
So Yojana, otherwise normally the swimming pools and all also have not opened up yet.
Yes, ma'am.
So I mean, I'm sure there'll be a lot of apprehension about stepping into a pool which is similar to a swimming pool, right?
So, ma'am, the chlorine in this pool is minimal as compared to the other pools. The filtration systems, we have UV, we have ozone, and we have glass bead filters. And the BMC has given permission for therapeutic pools. So, and we have been having a lot of elderly clients, a lot of pediatric clients who have been coming for therapy. So with new clients, they might have an apprehension, but with our old clients who have been taking treatment with us for a very long time, and due to the lockdown, the effect of aqua is amazing now. So they have been coming regularly, and inside the pool, the contamination level is almost 0. Above, we are maintaining the mask, and we are having the face shields and the proper protective gear to take care of the client.
Yojana, as far as I know, normally when a patient is in, you are rehabilitating the patient with therapy. I remember from my granddad's schedule that you used to ask them to come twice or thrice a week, right? So then how frequently do you do the COVID test? Because the COVID report for a single time cannot be valid for every visit that the patient is doing, and exercising with a mask on is generally not recommended. So, how do you go about that?
So for that procedure, what usually we do is, as a therapist, every 15 days, every fortnight, we get ourselves tested for COVID. And once the client comes in, if we ask for the history, so if the client is having a travel history, or if the client is having an exposure history at home, which is very indicative of something coming up positive, then we probe the client to do a repeat test. Until unless that is strong history is coming up, we consider the first test and we go ahead with the rehab.
Okay. Thank you. Any more questions, Riddhi?
I think you can stop sharing the slide, Yojana.
Sure,
then, yeah.
I wanted to ask one question to Dr. Geeta Balsarkar. That suppose a patient comes to us and we can want to combine MHT with non-hormonal alternatives. So is it that then MHT dose we have to reduce and add non-hormonal, or is there any personal experience or any other study which tells us about a combination of hormonal therapy plus non-hormonal therapy? Is Dr. Geeta is there?
Dr. Geeta?
No, no, I don't think.
I think she's got logged out. Maybe we can take the question again, ma'am.
Yes.
Yeah. Riddhi, you can take over, I think, for the next session.
Thank you so much, chairpersons, for taking out your time, your valuable time in being here with us. And thank you so much to our speakers for giving us such interesting, new and practical concepts. Now we'll be hearing from our president, Dr. Ashwini Bhalerao, ma'am. Can I have her slide, please? Of course, ma'am needs no introduction to this august audience, but it is my privilege to introduce her. She is a consultant gynecologist at PD Hinduja Hospital and Hinduja Healthcare Surgical Mumbai. She has been the past vice president of FOXY and past president of MOGS. She has been the chairperson of Adolescent Health Committee of FOXY, and she is the ex-associate professor of TN Medical College in Nair Hospital. She is a secretary of JOGI, Journal of Obs and Gynacs of India, and she is a consultant gynecologist at the Valva Clinic at Hinduja Hospital, Mumbai. Over to you, ma'am.
Thank you, Dr. Riddhi, for the introduction. I'm not going to take any class or lecture. I just wanted to talk with the participants, our faculty, as well as the delegates who have joined. And I'm so happy that I had shared our program with a few of our All India members of Indian Menopause Society. And most of them said that we would like to attend because maybe the topics were different. That is, one is non-hormonal therapy plus the aqua therapy. Definitely it is something very novel, and yes, it is very upcoming, though there is little hesitance. I understand that, anybody especially who is not used to swimming and not used to going into the water, suddenly going in the aqua center and getting aqua therapy, it may require a lot of efforts and counseling. I'm sure that is required. And also the next topic of panel, that is obesity in midlife. It is problem of all of us, I think, and maybe that's why many of us are interested in listening to the experts, that what they have to say. We have a very good panel, and here I would like to mention Dr. Priya Vora, who is our joint secretary of Mumbai Menopause Society. That she has put in lot of work and efforts in organizing this program, and Kinjal Shah and Riddhi Desai, they have helped us in being conveners of this program. So I just felt that I should extend my thanks to all the faculty members plus the delegates who have logged in. And also I cannot forget Shield Company, who has given us support academic for this academic activity. So I'm sure all of us, we would like to now listen to the panel. So it is over you again to Riddhi.
Thank you so much, ma'am, for your for joining us and giving us this presidential address. And now we would like to start with the panel, as madam said, which is on obesity in midlife. So for that, I would like to call upon our moderators, Dr. Neeta Dalal, madam. Madam is a consultant OB/GYN at Saifi Hospital, visiting consultant at Breach Candy Hospital, ex-associate professor at the LTM GM Hospital, and the president, the past president of Mumbai Menopause Society 2017 to 19, and has done many research in the research committee of Abhiyan PCOS India. A second moderator is Dr. Priya Vora. She is the joint secretary of the Mumbai Menopause Society, the MOGS managing committee member, and our youth council mentor, youth wing of the AMWI, and received the MOGS Durusha Best Committee Member Award twice. So I hand over to the moderators to start the panel. Dr. Priya?
Yeah, Kinjal, can you hear me?
Yes, yes.
Yeah. So we are starting this important panel with my co-moderator, Dr. Neeta Dalal. The topic is obesity in midlife and fighting the battle of the fat. Yeah,
Hello.
Madam Neeta Dalal. Yeah.
So, for this very important topic, let me speak a few words before we start. That obesity remains a major public health challenge across the globe. And even if in a poor country like ours, in India, where there is so much prevailing hunger, the number of obese Indians are just increasing. They've jumped from 12.6% to 20.7% in the last one decade. And if we couple this with our genetic predisposition for metabolic syndrome, the end result is a huge burden on our healthcare system. Today, we have a star-studded list of panelists that I will introduce and who will all give us tips on winning this battle of the bulge. Like Dr. Ashwini said, we are all many of us are still fighting this battle of the bulge and we still need to win it. So let's begin with Dr. Sarita Bhalerao. She is the consultant in Bridge Candy Hospital, Reliance Saifi Bhatia Maternity Hospitals. She is the Vice President of the Mumbai Obs and Gynec Society. She was a member of the Governing Council ICOG 2018-2020. And she is the chairperson of the AICC RCOG West Zone. Dr. Kiran Koilo has an emergency and cannot join us. In her place, Dr. Rita Shah has very kindly agreed to join the panel. She is a physical therapist who has been very closely associated with the Mumbai Menopause Society since its inception. She has been the past secretary of our society and the treasurer of the Indian Menopause Society. She is currently the director of 9 months pregnancy classes. We also have Dr. Shubhda Gupta, who's practicing obstetrics, gynecology, and in vitro fertilization at the Marathon Max, Mulund and Bandung since 20 years. And she has been associated with Dr. Hinduja for IVF pregnancies. Dr. Kanwal Panu is a senior consultant, obstetrician and gynecologist at the Indu Clinic in Kolaba, and she has more than 30 years of clinical experience.
Dr. Ritu Jain, she's practicing in Malad since 20 years. She's a consultant at Sanjeevni Hospital, Sai Kripa Hospital, Cloud9 Hospital, with a special field of interest is high-risk pregnancy, midlife management, and infertility. Dr. Vijaya Babre, she's an associate professor and a unit head at JJ Group of Hospitals and Grand Medical College. She has been a managing committee member in 2018 and 19, and she is a part of the youth wing of AMWI. And we have a bariatric surgeon amongst us, Dr. Biswanath Gowda. He is a consultant at Holy Family and St. Elizabeth Hospital with his expertise in GIT surgeries, laparoscopic surgeries for the liver, gallbladder, pancreatic disorders, and bariatric surgeries.
So let's start the first question. Dr. Shubhda Gupta, can you hear me?
Yes, madam, I can hear you well. Can you hear me?
I can hear you.
Fine. Yeah.
So, Dr. Gupta, which women would you call obese? And what are the parameters that we can use to evaluate obesity and say that this woman is obese?
Right. So basically, all of us know what is obesity. Just being above one's normal ideal weight by 20% increase is, in simple words, is obesity. Now, medically, it is a complex, multifactorial, and chronic metabolic disorder, and not just excess of adipose tissue. And this excess of fat is to such an extent that it does cause lot of adverse health effects. Now, to simplify, WHO has formulated an index, and it's called as body mass index, which is based on weight in kilograms, and its ratio of weight in kilograms to the height in square meters. Now, as you can see on the slide, the criteria definitely are a little different as far comparison with Caucasians and Indians go. Though internationally, we call obese patients who are above 25 or other overweight above 25 to 30 BMI. For Asia Pacific or other Asians, this is between 22.5 to 27.5. Those who are between 31 to 40 are called obese. And for Asia Pacific, this is again different. It is between 32.5 to, 27.5 to 32.5, which is obesity of grade 1. 32.5 to 37.5 is grade 2. And those who have BMI of above 37.5 are called as morbidly obese. Now, basically,
so Dr. Gupta, measuring the BMI is one parameter for measurement. What are the other parameters we can use to say this woman is obese or not?
So obviously, so when you consider weight against height, so you sometimes tend to neglect those who are really muscular, those who are very well built, and those who are very, very tall. So you may not always know who is exactly obese and who is at risk. Now, basically, the classification is to find out those who require active management. And for that, the abdominal circumference actually gives us a good overall insight into the obesity related problems. So waist circumference is one such important parameter.
Priya, can you share the slide, please?
So what we say is, for Asian women, the waist circumference of more than 80 centimeter falls straight into obese criteria. For men, it is above 90. And for the basically waist circumference above 102 centimeters, and for men, and 82 or more in women makes them morbidly obese. So these are the ones who definitely require immediate attention and need to undergo treatment for their obesity.
So
now, there are certain more things.
So Dr. Gupta, just to interrupt, can you clarify that measuring the BMI can give you a false sense of either the woman is obese or not? So what is the confounding factor, and what can we do to really confirm that this woman is obese?
So one of the things is, along with the BMI, we need to take the waist circumference. There's also a ratio of waist circumference to the hip circumference, which gives us fair idea about the central obesity, or basically the visceral fat. There are many more things which have been thought about to find how one can measure the obesity. So neck circumference is one such thing. Arm circumference is another thing. Ratios of neck circumference and waist circumference and the height are also taken into account. There are different ways to calculate it.
So Dr. Gupta, basically, that the problem arises when when there is somebody muscular, because the BMI cannot distinguish between fat and muscle. They just need the weight and the height. So when we have these patients who are muscular and you don't know their body fat content, are there any machines which can help us to find out the body composition?
Yes. There are lot many new and commercially available machines now.
So anything
So
that dietitians routinely use
yeah. So
in their
there is
clinic?
this. It is also available in our basically different gyms, and you just have to stand on that basic machine where you actually find out the impedance to the electric current, and that gives you the fair idea about percent
of the
of
fat percentage.
fat and your muscle mass. Yeah.
So the next question goes to Dr. Kanwal Pannu, that we lay so much importance on waist circumference, Dr. Pannu.
Yeah.
But I have found in my clinic that when I speak to women.
Yes, ma'am.
Can you hear me? Yeah.
Yes,
so I have
ma'am.
found that when I speak to women in my clinic, either they don't measure the waist circumference correctly or they are cheating. So can you tell us in your clinic, in a practical way, how do you measure a woman's waist circumference?
Okay. First of all, I'd like to thank all the organizers for giving this opportunity to someone who's not a frequent speaker. Thank you. So there are 4 points to be kept in mind while measuring the waist circumference. The first thing is to stand and place a measure around the middle, just above the hip bones, what we understand as the anterior superior iliac spine. And this tape should be at level with the belly button. The second thing is that make sure that the tape is horizontal around the waist. It should be a flexible tape measure. A cloth tape measure is always better. Third, keep the tape snug around the waist, but not compressing the skin. And the fourth thing is that measure the waist just after you breathe out. Check the number on the tape measure right after you exhale. And this is so a simple method to assess abdominal obesity. And it's useful for identifying individuals who are at increased risk for metabolic complications.
Thank you. So the correct way is not to pull it too tight, and that you have to measure it when you exhale, not inhale. That's the important thing. So can you also tell us, Dr. Pannu, that we all keep on talking about apple shape and pear shape and the menopausal woman moving from pear to apple. What is the significance of this apple shape?
Madam, the apple shape is as we consider versus a pear-shaped body. Apple shape describes people who have ample waists and tendency to gain weight over the abdomen. This is more common in men. Pear-shaped women have smaller waists and carry extra kilos in the hips, thighs, and butt. And like I said, this is more common in women because this is an estrogen effect. But the bottom line is that all the studies have said that apple shapes are worse than pear shape. Essentially speaking, pear is just a shape of the body, and it's a way to know where we need to lose weight. And pears can expect to become fitter and toned, but total change in shape is tough because body fat stored in the thighs, legs, and buttocks is less metabolically active and so more hard to burn off.
So, Dr. Sarita Bhalera, would you like to come in on this one? What is the importance of the apple shape? Has Dr. Bhalera joined us?
Hi, I'm here, Nita.
Yeah, just very briefly, can you tell us on the apple shape and why is it a high risk?
Because what is dangerous is actually visceral fat. More the visceral fat that is much more dangerous for it's a cardiovascular risk factor. So I think that that is the main issue, and that is why and what happens with menopause is that as estrogen levels fall, it's been shown in labs that animals tend to become less active, tend to eat more, and there's central obesity, and that central obesity and accumulation of visceral fat is what is a main cardiovascular problems.
So so the central obesity is a risk marker for cardiovascular disease.
We'll go to the next question.
Yeah.
Dr. Ritu, can you enumerate the problems associated with obesity?
Yes. See, as we have already described, it is a chronic disorder. So
I would request others who are not speaking, please mute yourself. It's causing a lot of disturbance. Yeah, Ritu.
yeah, so obesity related comorbidities, we can categorize them as metabolic, like type 2 diabetes, hypertension, dyslipidemias, non-alcoholic fatty liver, gallbladder problems, and PCOD. Then inflammatory disorders like coronary artery diseases, asthma, osteoarthritis, gout, and degenerative joint diseases. Then structural morbidities starting from top, like migraine, obstructive sleep apnea, obesity, hypoventilation syndromes, then gastroesophageal reflux disease, urinary incontinence, venous stasis, thromboembolic diseases, and plantar fasciitis. Then cancers of breast, colon, ovaries, endometrial, and adenocarcinomas of the cervix have been related to obesity. Psychological problems of depression, anxiety, eating disorders. And now since pregnancies have been pushed to midlife, so pregnancy related gestational hypertension, gestational diabetes and
the medical issues.
Yeah, leading to increased rate of cesarean sections and later on breastfeeding issues. Then moreover, obesity itself worsens and it decreases the treatment efficacy of so many diseases. So overall, obesity related problems are countless.
Yeah, you well covered most of them. I just wanted to just highlight two important slides which I have made. That one is even the perimenopausal and in menopausal women, when the patient is obese, the symptoms like hot flashes or all the physical symptoms of menopause are much more in intensity and frequency. And when most studies have shown that when there was a decrease in the weight, definitely there was an improvement in these vasomotor symptoms. Also, midlife overweight has a link with dementia later on in life. So these are two important things, that people who are obese are at a higher risk of getting dementia in the midlife also. And as you've rightly said about the various cancers, the colon cancer, the breast, the uterine, and the endometrium.
So we come to the third question for Dr. Bhalerao. Are menopause and weight gain related? And what are the effects of aging in general and ovarian aging on weight and muscle mass? Can you take that, Dr. Bhalerao?
Yes, thank you, Neeta. What happens with menopause as estrogen levels fall, there is a fall in the basal metabolic rate, and studies have shown that as people age, they tend to eat more and they tend to be less active. Again, as muscle mass falls, there's a tendency to accumulate weight. So it is a factor of aging, it's a factor of lifestyle factors, and there's definitely a factor of estrogen deficiency. All together, this adds to weight gain at menopause.
So, as rightly said, Priya, can you share the slide, please?
Yeah.
There is a 4% drop in basal metabolic rate per decade of life after 50 years. And a lot of it is linked to the loss of muscle mass. Now, as you can, the same slide is explaining exactly what you have said, that the loss of lean body mass also decreases BMR, loss of activity, and people continue to eat as they did earlier without decreasing the number of calories. So it all adds up. So the next questions, Dr. Sarita, will HRT prevent this midlife weight gain? What do you think? And can you recommend it for prevention of weight gain? What are the changes of HRT if you give HRT and menopause on weight gain?
No, so the thing
Priya,
here
can you
is
change
that,
the slide?
yeah, so the thing is that there are, giving HRT for weight gain, I don't think is a very sensible thing. One thing is that this is a long-term issue, and giving HRT for long-term has its own risks. And the second thing is that there are so many other factors involved. It's not only estrogen. There are factors of aging, there are factors of activity, there are factors of diet. So just by giving menopause hormone therapy, you can't maintain a perfect weight. So I agree completely with this slide, which says that HRT use is not recommended for the prevention of for chronic disease or management of weight gain.
But if you happen to give it, say, for vasomotor symptoms, okay, is there any benefit to this patient or not, as far as weight gain goes?
With regards to weight, the maximum benefit is with lifestyle modification, with exercise and diet. This may help to some extent, but and when we give it for hot flashes, we are giving it for a short-term benefit.
Correct. So what studies have shown is that if you give HRT, it can prevent the shift redistribution of fat, or it can delay the redistribution of fat and slow down loss of muscle mass. Of course, you don't give it for long. So as soon as you stop the HRT, the menopausal changes are going to kick in. But while you give it, there is some degree of protection. Priya?
Yes. Briefly explain the different treatment options which are available to us for obesity management. Dr. Vijaya Babre, if you could just enumerate them quickly. Yeah, Dr. Vijaya?
Yeah. First of all, whenever we are talking about the weight reduction, we need to do around 5 to 10% of weight reduction of a total weight, and it has to be definitely multidisciplinary approach. And the patient, the first is diet, which plays a very important role in obesity management. So diet should have more of proteins, green leafy vegetables. Nowadays they are saying the vegan and the vegetarian diet is better when we are talking about control of the obesity. Cut down on the calories, cut down on the cold drinks. Again,
diet we'll be discussing a little later. Just enumerate.
And then the physical activity, the exercise, the muscle strengthening exercises, and the resistance training exercises help in the weight reduction. Then behavioral support is very important thing, because the stress relief counseling support group, which plays an important role, because as the patient in this menopause going through many hormonal changes, are under stress, and that again one of the factor which increase in the weight. And weight loss medication can be incorporated in case if the diet and the exercise is not able to control it, then orlistat or metformin can be used in that. And the last role of the bariatric or the endoscopic surgeries, when it is we are talking about the morbidly obese patients.
Yes, Vijaya, you well covered it. Metformin, definitely if a patient is obese and she has a risk of diabetes, or she's already a diabetic, then it may help.
Yes.
Yeah. Now, lifestyle interventions, we all know our diet and exercise. But however, the worldwide, we wanted to know what are the success rates we have with the lifestyle interventions for the weight loss. Dr. Shubda, if you could take this. Please unmute yourself, ma'am.
Yeah, so lifestyle intervention has shown a success of mere 6 to 8% of weight loss over 6 to 12 months. Now, generally for any treatment to be successful, we consider it successful only when it causes reduction of weight by 5% at least over about 6 to 12 months. So there is really, like, patient needs to persist. Patient needs to be really supplemented with medications if required, and this has to be kind of their lifestyle forever. They cannot just stop doing what they're doing after they lose certain amount of weight. But as far morbidity is concerned, there is definite improvement in the risk related to cardiovascular and stroke and diabetes if they're able to reduce their weight by at least 5%. The same as we have been explaining to our PCO patients. So moderate obesity with comorbidity and severe obesity definitely needs more treatment than just lifestyle intervention. Now, along with the lifestyle intervention, there are certain drugs. So do you want me to talk about the
No,
drugs?
I'll ask you later. The question will come. So this is very important, which we all need to understand. Lifestyle intervention definitely is helpful, but in patients with moderate obesity, with comorbidity or severe obesity, they definitely need something much more, either in the form of a pharmacotherapy or bariatric surgery.
Correct.
Absolutely.
Coming to this, Vijaya, if you could just highlight quickly important aspects of the diet which we normally recommend for weight loss.
Diet should be more of protein, less of carbohydrate, then green leafy vegetables. Then as we are talking about in a menopausal, so they can add in the broccoli, flax seeds, which are more into have the phytoestrogens. So that can be incorporated into the diet, and definitely making more healthier choice rather than bring along with the diet options available. And the frequency diet, everyone knows what is healthy diet, but to what is the frequency of diet. So they can have the 3 proper meals, and whenever the subsidiary meals or the small portion they are taking, that has to be more healthier. That should incorporate the fruits and the low calories. Otherwise, that is the main cause patient will have the weight gain. So that is how the diet modification is required, and it plays a major role when we are talking about weight management.
Yeah, so according to the American Cardiology Heart Association, the caloric deficit is the most important in a which should be about 500 to 750 kilocalorie, and the most of the diets recommend a low carbohydrate in the diet. However, the ideal micronutrient, yes, definitely needs further investigation, because different diets recommend different nutrients, but all our menopausal women are low in iron, calcium, and phytoestrogens, and this also needs to be added. I wanted to ask Dr. Sarita, madam, that why do the diets fail? We see all our patients, they tend to lose weight fast initially, and suddenly then the weight doesn't just budge. It comes to a stagnation. Why is this, ma'am?
See, whenever you change the diet or you go on a diet, the first bit of weight loss is going to happen. The problem is the sustainability. And that sustained weight loss, maintaining that weight is the most difficult part. Some people lose interest, they lose motivation, they find it too difficult to do. And slowly, you have to, it's eating habits. I also find that certain people, why do they eat more? Sometimes there is something called mindful eating. It's also, you have to think about why they are eating. Are they eating because of anxiety? Are they eating because of depression? Or are they eating because they are hungry? So I think that there's a lot of different factors when it comes to failing. And I think that the only way is a multidisciplinary team, like we have Dr. Gowda here and we have so many others here, and that multidisciplinary team and the sustained effort and that continuous motivation is the only way it will work.
Yeah, the most important is that when the starvation also occurs, definitely, and because of the hypocaloric diet, our body, it has a defensive mechanism and it tries to slow down even the loss of the energy. So this is also important, and the weight definitely stagnates. And this was by the Mayo Clinic, where they found that when there is a stagnation in the weight, then you need to reassess your eating habits, cut off the calories, and increase your intensity in the workout and pack more activity into your daily life.
So one sec, Priya, can I come in on this?
Yes,
Just a
ma'am.
comment that the people who have lost weight and like Dr. Gita said, it's a uphill task because the body we call a set point, and that set point is for the current level of fat content in the body. When you lose, like you said, the body goes into starvation and it thinks it is being starved and it starts making hormonal adjustments. But resetting it takes 1 year. So you have to have the patience for one
To
year
continue.
till your hypothalamus readjusts.
Yes, ma'am. You can continue, Neeta, ma'am.
So, Risha, are you there?
Yeah, Dr. Rita, ma'am,
Can you
is
hear
there.
me?
Yes, I am here.
Okay. Can you hear me?
I can hear you.
So we have heard about the importance of exercise. So far, we've had a talk and we know that it is generally beneficial. Can you tell us what is a good exercise plan which complements a good diet? You know, it's like a yin and yang. You cannot have a diet without exercise and vice versa. So can you give us a good exercise plan which will decrease lifestyle failure rates?
Yes, Dr. Neeta, you are very right that diet and exercises have to go hand in hand for us to get the best results. Now, basically, in our country, we really do not have a good concept of an exercise program plan. Whenever somebody decides to put in some kind of physical activity, the first thought that strikes the person's mind is from tomorrow morning, I'm going to start walking, and they really become very serious about the walking issue, and they walk for days and days together, but they don't achieve the results that they are supposed to be getting. Maybe a few pounds are lost initially, but then as everyone has mentioned, it plateaus down. So let us understand that why is it that it's only walking that does not help, and which everyone gets attracted to start adding to their physical activity. Firstly, it's the simplest form of exercise. You don't require any kind of gadgets, you don't require any kind of preparations. So that's why it is very simple and easy. But when a person is very serious to gain some kind of results, like she intentionally wants to lose weight and she wants to become healthy, a proper plan is definitely necessary. So the exercise that she does, the walking is okay, but she needs to give importance to the strengthening or the muscle resistance exercises. This is very important because walking is just a part of the aerobic workout, but strength training, as the muscle mass gets lost with age, becomes a very important aspect that needs to be taken care of. Also, if her balance coordination is not very well maintained, she's going to fall with osteoporosis in her body. She might fracture herself and everything will come to a standstill. So a proper exercise program should consist of not only aerobic activity, which the person can choose. She can do walking, she can swim, she can cycle, she can go to the gym. But along with that, some kind of strength training is very essential, which can be done even at home. There is no need for her to join a special gym. Just using just very simple devices, water bottles, or even other things in the house which could increase the weight levels. She can do these simple movements by contacting somebody and doing under guidance. Of course, balance and coordination can greatly be improved with those specific exercises, but the most important part is stretching. After every exercise program, whether it is walking, whether it is strengthening, it is very important to stretch out the worked out muscles. If this stretching is not incorporated, what happens is the lactic acid that gets built up because of the exercise program in the muscles will make her muscles more sore. And that will really put her off the exercise program. So ideally we say a warm up and a cool down is very essential. But in case if the person does not have the time to do the warm up, at least she needs to cool down very well by doing specific stretching exercises. And these are very simple and can be taught just in a day or two, and she can do it for the rest of her program. We
Thank you.
insist on, yes.
Yeah. So, can you continue?
Yeah. So we insist on building the muscle mass, and that happens only with strength training or resistance training, as it is called. Now, I have known of so many women who dislike the strength training part of the exercises. They don't mind doing aerobic workout, they don't mind doing stretching at the end, but when it comes to resistance, they generally want to shy out. So it need not be done on a daily basis.
So
maybe 2 or 3
as
times
you
a day
rightly
can be
said,
incorporated.
So as you rightly said, Rita Shah, that we need to incorporate resistance training in the workouts that we give all our women, specifically because we know that the statistics are against us. And with every decade, we are losing about 8% of muscle mass. And by the time we reach 80, we have lost almost half our muscle mass.
Right.
Now, there is one more issue. Dr. Ritu Jain, these women often have joint mobility problems. You know, they have early osteoarthritis or they have aches and pains. What will you advise them about exercise when they have these problems? Is there something you can advise them?
Yes, ma'am. So when the joint is warm, pain and swollen, definitely they have to rest the joint so that the inflammation goes off. And once they are relieved of that, then gentle stretching exercises should be the best form of exercise for them. And they can do these gentle stretching exercises in the hot tub or a warm bath also. That will release the stiffness of the joints, especially that they have in the morning. Then the full range of motion movements is very helpful for them. And Tai Chi, which is the Chinese thing, which involves the gentle movements of the whole body and which concentrates on their breathing also, is definitely have given a lot of results in arthritis patients. Then once they are comfortable with this kind of stretching exercises, because now they have the flexibility of the joints, so now they can move on to the isometric resistance exercises. So that involves isometric exercises, particularly they don't involve the movement of the joints. So they give strength to the muscles, and this strengthened muscles, they release the pressure on the joints. Slowly they can again move on to the isotonic exercises, which involves the joint movements also. So once they have gained the strength of the muscles and seen the response to all these, they can progressively go on to the aerobic exercises also. So the general, what we should advise them is to do a moderate amount of physical activity in the daily life also, because that will decrease the fatigue. It will improve their sense of well-being and give the flexibility to the joints. So this I would advise the patients with the joint problems.
Can I continue? Yeah. What are the indications of adding the drugs or pharmacotherapy to the lifestyle interventions? Just be very brief, and in your practice, what you all have used, I just will ask 1-2 panelists. Dr. Gupta, what have you used? Which are the drugs in your private practice?
Yeah, so a lot of patients want to know what is this magic pill which can help them. So we keep telling them that there is no such magic. Lifestyle measures has to be continued. So unless like medicines or surgery is only a tool, if they want to continue to remain healthy, they need to actually follow a good lifestyle. So now coming to the drugs, generally,
just enumerate them.
Yeah. So there are drugs which we can say safely in 3 categories. One is to reduce appetite, Second is the one which reduces absorption. And third group is where you can increase the fat burning. Now, normally what we use in our practice is one common thing is the lipase inhibitor or reversible lipase inhibitor, that is orally which prevents hydrolyzation of dietary fat from triglycerides into absorbable fat. Yeah, so that is one which is used commonly. Yeah.
I'll
want
just
me to tell
no, fine. I would just here interrupt and I would ask Dr. Biswa, is it direct surgery or do you even try some drug management in your practice?
Okay.
Yeah, Dr. Gowda?
Yeah, can you hear me?
Yes.
Yeah, first of all, thank you very much for giving me this awesome opportunity to reach out to you all. Your question is very interesting. See, when the patient comes to me, most of the time they have gone through all the phases which we have very elaborately discussed: the diet, exercise, behavioral support, going to a gym multiple times, paying annual fees, going to a weight consultant. So they have gone through all the phases and then they land up to me. I have not seen any patient who would come straight away for surgery. So that's why our life becomes much simpler. So we don't have to give them diet. We don't have to tell them you exercise. We don't have to tell them go and join a gym. So they've done that. But I think in this particular segment of menopause, most of the patients, they are not really morbidly obese. They are not like 40, 50 kilos overweight. They are trying to lose that 10, 15 or 20 kilos max. And I think they should be given the right possible diet, which is low carbohydrate, high protein, and maybe a little bit of drug, orlistat or metformin, to see for 3 months or 6 months if it helps or doesn't help. But at the same time, motivation, I think, is something which is very important, because the estrogen comes down, your muscle starts reducing, your fat deposition increases, and in this group, most of the kids are also gone to college or moved ahead. So you have almost like a loneliness. So there's also behavioral modification which is needed. I think giving that strategy, we would be able to help most of the patient. I think very few people will come on the OT table for surgical approach.
Yeah, only thing what I would like to bring out is definitely with these drugs, since we need to take them for a long, there are issues regarding the long-term safety. So that and side effects of these drugs we need to keep in mind, definitely. So these are just the FDA approved drugs. I'm just gonna continue. Yeah. Neeta ma'am. Dr. Neeta Dalal.
You have to unmute, Neeta.
Oh, sorry. Dr. Gowda, we are back to our expert. So you just spoke about patients having tried everything and then coming to you for surgery. Now, my question to you is, do you operate on every patient who comes to you for bariatric surgery, or do you have stringent criteria? Can you tell us what they are?
Yeah, thank you, ma'am. I think that's also a very interesting question. No, I don't operate on anyone who comes to me for surgery. First of all, there are very clear-cut guidelines, although it's not watertight, which is followed in India or mostly in Mumbai, because most of the surgeons are very happy to operate anyone who lands in the tier for their consulting room for bariatric surgery. But I'm telling you, I don't operate on everyone. As I think one of the panelists has discussed the obesity criteria, we can see in Asian patient our BMI is definitely less, which is 27.5 onwards, whereas the international guidelines it's about 35 or maybe 40 in US. US, unless the BMI is 40, they can't even qualify for a surgery. Whereas in an Asian population, it drops all the way down to 27.5. That is one criteria which we look at it. The other is patients having comorbidities like diabetes, blood pressure, or recent history of osteoarthritis, sleep apnea, OSA, PCOD, some of the patients with morbid obesity. There we have seen or have seen been operated for BMI of 25 also. And to be honest, in India, most of the patients are asking for surgery even when the BMI is not up to 25 or 27, especially in younger generation. In 20 to 25 of age group, we have seen patients who are just maybe 20 or 30 kilos overweight, and they want to get the surgery done. but that is very commonly seen in Mumbai, which I think doesn't fall into the BMI criteria, but that is off the hook. So
So I
answering your
suppose that is
question,
an easier option, right?
yeah, it is easier. I think in the short term it is easier, but in the long term, this young patient don't have a good follow up. Maybe they'll follow for 2 years or 3 years, but the long term effects like micronutrient deficiencies, muscle
Right.
mass loss, all this comes only after 5 years onwards. In fact, recently one young lady about 26 years old, she had underwent a sleeve when she was 21-year-old, and now she has a uterine prolapse for which she was to be operated. So this which you would not
Okay.
see in a young girl, but because it is not done for the right patient and because they don't follow up, having at least follow up with 5 years, 6 years, we still don't know whether. I think it's not right to operate on a very young patient if it doesn't fall into the criteria. That's my
Right.
opinion.
So before we go on to different forms of surgery,
Yeah.
I wanted to ask you, there are those hydrogel sachets which are available, which you can swallow before every meal, and it swells and it takes up space. So are they available in India, and how effective are they?
Yeah, that's. I think you are very up to date about the non-surgical weight loss. That
Yeah,
hydrogel
because
is.
that's the only thing we can do, right?
Yeah. That hydrogel was approved by FDA in 2019, and it
Yeah.
just hit the market last month in October in US. We still don't. It's not available in India, and it's not even on Amazon right now. But it's a very good hydrogel. It's form of cellulose and citric acid. So you can take with a meal. Before a meal, half an hour before a meal, you can take those capsules. So they will swell up in your stomach, and it will fill up your stomach. And as a result, your stomach will give a sensation that you're full. So once you get that full sensation, your amount of food intake reduces much less. And that gel capsules goes all the way through intestine and comes out. And the intestine, stomach, everything gets stretched. So once that stretch reflex is initiated, the brain gets a signal that you're full, you don't need to eat more. And this capsules is good. There are no side effects so far reported in the literature, even by the company. And it is helpful only on those patients who want to lose about 5% of their excess weight. So if you are about 5 kilos overweight, you can try this initial therapy. And it is, it's so the results have shown it's really works well. That is one which is non-invasive and it doesn't have long-term effects on the body. Yeah. I think we should be able to get it
So,
in India in some time. Yeah.
so while we wait for the capsule and the gel,
Yeah.
can you very briefly tell us that bariatric surgeries, which is the most common surgery that you do in your practice? Which are the 2 or 3 most common surgeries?
Sure. So these are the 4 most common weight loss surgeries done across the globe. Out of which the
Okay.
lap band, which was done initially, is out of flavor right now because it had a lot of complications. The band used to slip, the band used to erode, and the gastric volvulus used to happen. So the gastric band is out of picture. The most common thing is the gastric sleeve. Around the globe, about 80% of the time, this is the gastric sleeve, which is the most commonly done procedure. After which is the
Okay.
Roux-en-Y gastric bypass, which is about 20%. Uh,
Right.
in a, can I get the next slide? Yeah. Next. So
There's no
I'll
other
stick to
slides.
this slide. Yeah.
No, just
So
summarize in
yeah.
this.
So
Yeah.
in a gastric bypass, ma'am, we have 2 anastomoses. First, we reduce the size of the stomach, make a small pouch about 50 cc. Then we take the loop of intestine, stick it there, and make another intestinal anastomosis. So you have 2 anastomoses. As a result of which it is complicated. Chances of complications are more, and chances of bleeding and pouch enlargement are also more. But if a patient is severely obese and he is a diabetic and he's got some reflux or GERD, gastric bypass is a much better procedure than a sleeve. If the patient is high risk, patient is not overly obese, patient doesn't have diabetes, patient doesn't have hypertension, no ischemic heart disease, then gastric sleeve is a much better because there is no anastomosis. You just have to remove this excess part of the stomach. And both the procedures are done laparoscopic. So most of the patient stays in the hospital on an average 2 to 3 days, not more. And if a gastric bypass reverses or you want to see the patient is gaining more even after the gastric bypass, then you can do a more extensive surgery, which is a duodenal switch. Very few people are which needs that procedure. For on an average, most commonly done is a gastric sleeve, which is easier to do, less complication, and gives you the same result of weight loss. When you look at the data of 5 years or 10 years, the weight loss in a bypass as well as a sleeve, it's almost the same. It plateaus at the same rate. So yeah.
So can you tell us that when you do this surgery, right? Say it's a gastric sleeve,
Yeah.
how long do the effects last? Because from what we understand, that the remaining part of the stomach can also increase in size. So
Yeah,
can you
that's true.
tell us how
That's
long,
true.
how
That's true.
many years the effect lasts?
Yeah. So I'll give you a example. Like if the patient is 100 kilo weight and her excess weight is about 40 kilos, she has to lose that 40 kilos because the ideal body weight is 60 kilos. So after a gastric sleeve, she would lose 4% of the excess weight. That means about 4 kilos a month for the next 12 months to 18 months. So she'll come to an ideal body weight of 60 kilos in an average span of 12 months to 18 months. After that, the weight loss plateaus. And that's when we ask them to start doing good exercises so that they start doing more exercise, muscle mass, and what do you call cardio exercises. So to build and not only just to maintain the weight, but not to also to gain weight after that. The question of gaining this, increasing the size of the stomach. See, when we do a gastric sleeve, we remove almost 80% of the stomach. So remains is the 20%. So if a patient is either a volume eater or goes on high caloric diet after the surgery, then the chances that the stomach may increase to about 10-20% more. Or if while doing the surgery, if the fundus, if this part of the fundus has been not too dissected or not been taken off, then the fundus will almost grow to the size of the stomach. So that's a technical error. If you sometimes we have seen where the fundus is not removed totally. So after 1 year, the fundus will grow, and will almost become the size of the stomach, and the weight loss will almost come back to the same which he or she has undergone the surgery before. So yeah, weight loss is common if your diet is not improved. Yeah.
Yeah. I wanted to ask Dr. Gowda, what are the health benefits of bariatric surgery? If you could just enumerate quickly.
Yeah, I think all the complications of obesity, which I think one of the panelists showed us, the causes of obesity. Most of the problems are taken care with this bariatric surgery, and this is a slide which has come from Mayo Clinic also, which most of the women, and it is not just menopausal, it's overall any patient who undergoes a bariatric surgery with any of the symptoms, we have seen classical reversal: migraines, depression, OSA, high cholesterol, asthma, high blood pressure, and diabetes. Though we know very well that we don't talk about curing of diabetes, but actually it's a reversal of your diabetes. So your sugars usually doesn't go beyond the expected limits, and that we have seen not only with patients who are on OHA but also with on insulin. So type 2 diabetes and non-alcoholic fatty liver are very commonly seen good results with weight loss. When you once you start losing that weight, dropping down, your fatty liver which was seen before improves almost like to a pristine liver. And nowadays non-alcoholic fatty liver is one of the common causes for a liver transplant. So if a patient is obese and you have a NASH, bariatric surgery is much better than waiting for your liver to fail and going for a liver transplant. That's just off the hook. And PCOD, you guys all know PCOD reverses in an obese woman, and you have advocated for bariatric surgery, although it doesn't come first in the list, but it comes last in the list. But any which ways, but it's seen very classical reversal of PCOD in young women. So yeah, those is some of the benefits of a bariatric surgery, which is invasive, and that's what keeps most of the patients away.
Yeah, you well covered most of the points, Dr. Biswanath. I'm going to Dr. Sarita, madam. Can we suggest our patients that will the liposuction be helpful instead of bariatric surgery, ma'am?
Yeah, I'm not an authority in this area, but I think that they're two completely different things. It's like apples and oranges. Liposuction is a plastic surgery procedure in which the fat is removed and the body is reconstituted. And bariatric surgery, we are looking at long-term weight loss. So I don't think that we can compare the two. I think they're completely different. For somebody who wants to, change their shape, liposuction is fine. But if somebody who has morbid diabetes and wants to bring down the weight, we can't suggest liposuction.
Yeah, and most studies have shown that the abdominal liposuction, it will definitely improve the adipose content, but will not show improvement in the metabolic parameters. And that's really important for the cardiovascular risk prevention. And only very few studies have shown some benefit. So definitely we need to keep in mind about this. The key points I'll quickly summarize. Weight gain is a major health issue with the midlife. The fall in the estrogen definitely increases the central accumulation of the fat. The strategies for the weight reduction are lifestyle modification, that is diet, regular exercise. However, medications can also be added if the patient doesn't lose weight to the extent she wants to. And metformin can be given if they are overweight and those who have at a risk of diabetes. And bariatric surgery is recommended for morbid obesity with the metabolic issues also. Thank you. We would like to thank all our panelists for taking out the time and making our panel discussion very fruitful and interactive. Neeta ma'am.
Thank you everyone for joining us on the panel, and thank you Priya for all your hard work on making all the slides with me just telling you what we should write. Thank you very much.
Thank you, Neeta and Priya. That was a great panel. Enjoyed it. Thank you.
I'll just stop sharing.
We
can take a group picture.
On the behalf of all the panelists, I would like to thank Mumbai Menopausal Society for giving us this great opportunity, and our President Madam Gandhi Madam, Vice President Geeta Balsarkar Madam, and both moderators were fantastic, Dr. Priya and Dr. Neeta, and thank you for giving this opportunity. Thank you.
Thank you. Thank you from my side also. Thank you, everybody.
I would like to thank the moderator.
Thanks a lot
for such a fantastic discussion on a very rare topic and very important topic of obesity in midlife. So for the vote of thanks, I would like to sincerely thank Dr. Ashwini Bhalerao Gandhi Madam, the President of the Mumbai Menopause Society, for giving us this opportunity. Would like to thank Dr. Priya Vora for compiling this program with such interesting topics and all different varieties we had today. Would like to thank my chairpersons and speakers for sharing their insights on all the different views. Aqua Center for updating us with what options are available when we are treating with our patients. I would like to thank the moderators and the panelists for the fantastic discussion on obesity in midlife. Would like to thank my co-MOC, that is Dr. Riddhi Desai, for all her help. I would like to thank our educational partner, that is Shield, who is the makers of Estro G, DFRAC, and Accord. And like to thank, last but not the least, all our delegates, our faculty members for removing their very valuable time and joining us on this webinar. Thank you so much.
Have they taken a group photo? Just quickly, one of you all take.
I think the field person will only be able to take. Has he taken?
They're going to record the whole event.
Okay.
Yeah. I just took a screenshot. I'll just take one more. Everybody smile. Yep, done.
Okay, thank you.
Thank you, Neeta ma'am.
Thank you. Thank you.
Yeah, thank you, ma'am. Thank you, doctors, for that wonderful knowledge sharing session. And I would like to thank all the speakers and delegates who are spending their valuable time today evening. And hope you find this session very interesting and useful. And thank you from the Shield. So if you allow us, then we can wind this webinar now.
Yeah, how many delegates have joined